Duke Majan, CEO and founder of Duke Spine Institute. And today is 9/10/2019, September 10th. This morning, we are going to be performing a Duke laser disc repair for a patient who travels from the islands. I believe Curacao or Trinidad and Tobago. I'm not exactly sure which island, but our patient comes to us with 3 herniated discs in the neck, in the cervical spine, we call it, and they are pinching his spinal cord and his nerves, causing him to go paralyzed and to lose function in his muscles and feeling in his arm, actually both arms now. When I first reviewed his case, he was having symptoms only in the left side, and now he's developing right-sided symptoms as well in the right arm. In the beginning, it was just the left arm. So he had the choice of having a fusion done, and he chose to have the endoscopic surgery. All right. So I think this is a live surgery, by the way, so I'll be talking to my staff as we do the surgery. You're going to hear everything and see everything. We don't edit any of these videos. These are live stream surgeries around the world, real time. We are the only center in the world that just streams live surgery of the spine every single day in the operating room. We stream all of our surgeries without editing, so we're really the only place in the world that does that. And we stream every single one of our surgeries. We're the only place in the world that streams every single surgery. And of course, we don't edit our surgeries. So many times I do. I was going to ask for that. Many times if you go to the internet and you look at YouTube, you'll actually see edited surgeries. We don't edit our surgeries. So the reason we do real-time surgery editing, live streaming, is so you all can ask questions during the surgery, and I can show you things. But also so you can be part of the experience. Are you ready? So he's in a donut, right? He's extended, and he's relaxed. I'm not getting any response here from his skeletal muscles. I do like the idea of a little more extension, but he's probably okay right now. Shot. Let's see where we are. 2, 3, 4, 5, 6. Could be a little bit lower. Shot. 2, 3, 4, 5, 6. All right, let's go. Stay there. Shot. Let's go AP. Quick AP. I can't yet. Quick AP. That doesn't mean, it means you don't get everything perfect. I think I'm a little off to his other side. Shot. Perfect lateral. Two, 3, 4, 5, 6. Shot. 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 Let's get an AP. Coker. Take your time and get a good AP. All right, it's very nice. Little scoliosis you can see there. Back to a lateral. So we've entered the disc space through the skin and anteriorly. And I'm gonna have to fix both sides, both foramen. Shot. But I need to advance my needle to the center of the disc. We're going to do a discogram. Take 2, 3, 4, 5, 6. Everybody agree we're at 5, 6? Discogram? Yeah. We'll start at 5, 6. Shot. Now, you can see the dye has leaked out through the back of the disc in the epidural space through an annular tear. And that's really the main thing we're here to do, is to repair the annular tear and remove the herniation. Did you do another shot?
Yes, sir.
Right now, shot? Very good. All right. So I'm going to introduce my guide wire. By the way, there's no one else in the world that does this type of surgery except a few doctors. One of them is in Germany. I don't know if he's still doing these surgeries or not. These are endoscopic anterior cervical surgeries. And also the Koreans, the South Koreans used to do them. Shot? I don't know if they're still doing them. All right, how's our blood pressure?
Blood pressure, I am working on it. It's cycling right now.
So I'm just going to...
You like to keep it so you can feel the pulse?
No, not anymore. Now I want to keep it nice and low. Yeah. Initially, I want to feel the pulse of the carotid. But now, at this point, we want to minimize any venous bleeding. So we want to reduce. Perfect. Perfect. So, shot, you want to make sure your guide wire doesn't move while you're taking the needle out. So you want to check your lateral fluoro quite often. Now, we actually canceled this patient last week because the patient was taking a blood thinner at the time and wasn't aware that they were blood thinners, and we ended up having to cancel the surgery just for patient safety, just to make sure that we didn't have any issues with bleeding. And now the patient has been off of their blood thinners, and we injected 1 cc. Shot. All right, beautiful. So far so good. We're starting at 5, 6. That's the middle disc. I've injected some numbing medicine into the skin. We're going to make our skin incision now. You don't want to cut too deep with your knife. You could end up nicking the external jugular, or if you're really too deep, you can injure the internal jugular. But basically, I'm using the same shot. I'm using the same path or trajectory that we would use to do an ACDF. See this? This is probably not a good idea, right?
I have to fix it. Yes, sir. I have it.
Did I do that?
No, right now.
Yeah, I didn't think so. That was that way, right?
Probably, yes.
Yeah, you can't. We've talked about attention to detail, right?
Yes, sir.
Shot. Shot. All right. So I'm coming down to the spine with this dilator. Shot. Once I get to the anterior spine like I am now, I'm just going to get a quick AP to make sure I'm happy with where I'm at. I want to be in the midline or just very close to it. Shot. All right, Coker, AP. So this is again 5, 6. This is the number 5, 6 disc. It's the disc located between the number 5 and number 6 bone. And this is a reasonable size herniation, but the one below at C67 is huge. All right, that will be the next one we attack. So the tip of the dilator is in the midline. It's perfect. Our trajectory is off to the left side, which is his worst symptom side. Go ahead and get a lateral. So everything is going really well so far for our patient. The name of this procedure you're watching is the Duke laser disc repair. It's an endoscopic surgery done with an endoscope, just like arthroscopic shoulder or knee surgery is done, except it's done with one single incision, not two. shot, and it's done in the spine, which in the cervical spine, there's no one else in the world really doing anterior cervical that I know of at this time. I know the Koreans were really the pioneers many years ago, about 20 years ago, but many of them have stopped. And the reason they've stopped is that they've had some bad complications as a result of their surgery, which in my opinion, the way they were doing the surgery was not right. Shot? 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 So once we get started through the disc, then we can reassess and probably take out the guide wire. So that's what I intend to do. Try to advance it by twisting it, shot. So at this point I'm going to get the guide wire out and just advance the dilator, shot, by using a mallet, shot. Alright, so now we're at the back of the disc, right where the herniation is. And we've used this dilator to get there. Now I want you to look here, Zach. You see this tube? This little coffee straw? Metal coffee straw?
We see it.
The whole surgery is done through this tiny tube. This is the Duke laser disc repair. This surgery has been published, peer-reviewed and published in the National Library of Medicine. I think our first publication was back in 2012, so 7 years ago. We've had other publications about the outcomes from the surgery. And I've been doing the surgery now for 13 years with 0 complications to date. This tube is a little bit bent. This tubular retractor, which is probably still, it's fine. It's going down fine. I was probably just tugging on it during one of the cases. Some patients have a high collarbone and they make it very difficult to get access to some of the lower cervical discs. But the Duke laser disc repair shot surgery is really a surgery designed for repairing degenerated discs, herniated discs, bulging discs, any kind of a disc problem in the neck, which is really about 98% of cervical spine issues, is disc issues. You know, pinched nerves, herniated discs, neck pain, shoulder pain from the neck. So this surgery is a really nice surgery. It's an alternative to anterior cervical discectomy and fusion, which is called ACDF. It's also an alternative to, is he still pretty relaxed? Good. It's also an alternative to artificial disc shot. So instead of having a metal cage or disc or plate put in your neck, shot, you can have this surgery done. Are we sure he's relaxed? Because can you give me some inline traction? Oh, okay. That felt better. Stay there. Shot. 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 I felt it hit the bone spur. All right. So far, things are going well. I want to keep him really relaxed. Yeah. Otherwise, what happens is the cervical musculature spasms and clamps down, and the disc gets compressed, and it's hard for me to actually do the surgery then. So, our patient is under general endotracheal anesthesia. You have the pipe cleaner for this?
Yes, sir.
I will clean it out when you have a
Yes,
chance.
sir.
All right. So you can see the whole surgery, folks, is being done on the neck through a tiny 4mm tube. And like I said, in the United States of America, there's no other surgeon that does this surgery besides myself at Duke Spine Institute. And I've done over 1,000 ACDFs. I've done many artificial discs. But this surgery by far is the best, in my opinion. And the results are the best. The complication rate's the best. So people come from all over the world for me to do this type of surgery. All right, I'm bringing in the endoscope. We call this the endoscopic rig. And then we've got a fiber, watch yourself. The laser fiber is basically 0.5 millimeter wide. And I've got a camera. Can you all see this here, Zach?
We can see it.
Yeah, so this is the camera. It's a high definition camera. We have the scope here. We have the laser here. We have an irrigation source here. We have our light source here that provides illumination at the other end. And you have your rod and lens system here. So, in we go. Now, I'm going to have to adjust the focus just a little bit for you all. And I would bring the light intensity down a smidgen. And I'm going to use the grabber first. But you can see the blue down there. That's degenerated disc. That's one of the things we want to get out of here. I think one of the biggest mistakes people make, especially doctors, is they assume that the patient's symptoms should be proportional to the size of the herniation. And what I found is that that's absolutely not true. 95% of the time, you got to be gentle with that end. This is a $1,000 instrument, and you'll just rip the end of that right off. What I found most of the time is that patients with symptoms, it's always due to the annular tear and the herniated disc called the interposed nucleus within the annular tear being degenerated through the inflammatory process, chronic inflammation. So by removing the interposed herniation and debriding the annular tear, we can usually get rid of the patient's symptoms. And that's what we're going to do right now. So there's your annular tear, left to right. Hold on, I need to zoom in. I think our illumination is too much. We're overexposed. You can see the laser, that's a bone spur it's working on right there. Zapping it away. It's too bright. We need to turn it down. You don't just, yeah. This is the herniation right here, folks, that I'm getting rid of, the blue stuff. And right now I can tell you the tube is not moving very much because we haven't really gotten rid of much of the herniation, but I'm going to start manipulating the tube. This is the tubular retractor I'm talking about with my hand and trying to get this herniation out. Now we can get some of the bone spurs out with laser, but not all of them, and you don't need to get all of the bone spurs out. Our goal here is to get out what needs to come out, and that's it. So we don't want to do any more than we need to do to help this patient get better. And what I mean by that is there's a part of the herniation and bone spurs that are causing symptoms, and there's lots of bone spur and herniations that don't cause symptoms. We don't want to take out the bone spurs and herniations that don't cause symptoms. We only want to take out the bone spurs and herniations that do cause symptoms. If we're trying to take out every single herniation and every single bone spur, then we would be operating on every person alive. But the fact of the matter is that most people's herniations don't cause symptoms, and only a few do. And it's really the art of medicine is figuring out which herniations cause symptoms and which don't. And, of course, doing a treatment that works to fix it. There's that pink stuff down there was granulation tissue I was just zapping away. If you hit rewind, you could probably see it. But this is the laser that you're seeing at 12 o'clock. And that's a bone spur right there that I'm working on. And I'm very limited right now in the movement of the disc itself. But as I start to take out this scarred-in herniation and some of the bone spurs, you're going to see we'll get more and more movement. Okay? Well, I've got to rotate things around a little bit. I need that laser in a little deeper, so I'm going to go ahead and do that as well. That'll help me. Zach, any questions from our audience so far? This is all herniation, by the way, the blue stuff.
Not yet.
Nothing yet?
No, sir.
All right. This is all herniation I'm taking out right now, the blue stuff. Was there a question over there? So who do we have here?
We have Ben, June, Nico.
There's the dura down there. There's a herniation on the dura. Good. See how we're getting more movement already? As I'm getting rid of all this scar tissue. This scar tissue is here in the back of the disc because of the herniation. It wouldn't be here if there was no herniation. The herniation of the disc causes the inflammation, which then causes the scar tissue.
We have a question.
Sure.
We have a viewer asking, how do you figure out which herniation is causing the symptoms?
Great question. How do you figure out which herniation is causing the symptoms? That's a really good question, and it's a difficult question to answer in just a few sentences. So I'll do my best, but part of it is experience, me seeing so many herniations over the years and operating on them and knowing what results to expect based on the location of the herniation, based on the appearance of the herniation, and based on the patient's complaints, like their physical exam, their history. You know, I put all of that together, but basically there's no one easy answer. It's pretty complex. And in the end, if I'm not sure, there's a test I can do. It's called a discogram. And that's a bone spur, by the way. And the discogram is a really good test for figuring out which discs cause pain. So I use the MRI. I use sometimes a discogram. I use a physical exam. I use my experience treating this condition over all the years. And I use nerve tests many times, x-rays sometimes, CAT scans sometimes. But I take all that information and I use basically all that information to figure out where this patient or any patient's pain is coming from. There's not one simple answer, though. All right. There's some posterior ligament. Whenever you have a herniation, there's two types. There's contained, and then there's non-contained. Contained herniations stay pretty much underneath the ligament, and non-contained go outside the ligament and get into the epidural space or the foramen. Some surgeons don't understand the difference, and if you're not careful and you have a fragment of herniation that is basically, just keep it away from my face, that is underneath or basically outside the ligament, and you miss it, then you're going to have a problem with the patient still having their symptoms. So you got to make sure you get all the herniations, the ones that are subligamentous and the ones that are, extruded into the epidural space. So all of this is scarred down. This herniation is clearly very old. It's been there for a long time. I can tell it's been there for many years. Now, herniations don't just happen one and done. They can actually happen sequentially, meaning that a patient gets a small herniation and then a year later or 2 years later they re-injure it and get a bigger piece that comes out. So I'm over here in the right foramen right now. taking out a herniation in the right foramen. Right there. Pretty cool. And that's sitting on his right C6 nerve root. This irrigation is nice and cold. That's supposed to be. I see why the tube bends though. You really have to force it sometimes to get to where you need it to go. So we need to make sure we have enough of these tubes.
Yes, sir. We have plenty.
I would get more. Let's contact Wolf
Not a problem, sir.
and get a few more.
Yes, sir. I will do it today.
So hopefully that person felt their answer to the question was appropriate. There's a herniation right there. Stand by.
We have another question.
I don't think I got it. Sure.
We have a viewer asking, if you have symptoms in your left leg and your right leg, is it possible to treat them both in the same surgery?
So somebody said if you have symptoms in your left leg and right leg, is it possible to treat them both in the same surgery? The answer is yes, definitely. Not a problem to do that. So I tried to get the herniation out by grabbing it. Oh yeah, treat him in the same surgery. The answer is yes. We can treat them both in the same surgery. And Zach, I would appreciate it if you would post the answer in writing. Just you can do a short form of the answer.
Yes, sir.
But that way when people come back later and look, they'll see that it was at least answered in writing. Because I've gone back and looked, and I know we answer the questions verbally, but I know we don't, many of them look like they're not answered because we didn't put a written answer. So the main things from an anesthesia standpoint is we want really good blood pressure control, and we want good muscle relaxation. So how did I develop the surgery, the Duke laser disc repair? Well, about 14, 15 years ago, I went overseas and I learned the basic techniques from Korean, South Korean, and German surgeons. These are neurosurgeons and orthopedic surgeons. And I took those basic techniques and I brought them back to my practice and I tried them, and I found that I could improve on them and make them better. So I did. I did just that. And came up with what's now known as the Duke laser disc repair. Which I like to think of as not only taking the best from these other surgeons who were pioneers in this type of surgery, but also coming up with some of my own ideas, using my experience as a neurosurgeon and incorporating it into the technique to make it better. There is a big herniation here, and I'm trying to get it out. I may be able to get part of it now, but it's too big to take out through this tiny tube, so you have to use the laser to break it up into smaller pieces, and then you use the grabber to pull it out. There it is. That's one. So the surgery really is done not just with a laser, but also with what's called a pituitary rongeur. an endoscopic pituitary rongeur, which is a long shaft with a grabbing tip. Trying to float these fragments out. These are pieces of herniation, for those of you who don't know. Come on out. And you know, part of my job is to free them up. The other part is to remove them. So the visibility is not too bad. As you can see, it's actually better in the lumbar surgery. And the reason for that is the scope itself. This is what's called a fiber optic scope. So fiber optic scopes, they actually use fibers to transmit the image, like little glass fibers, whereas a rod lens scope uses, wow, that's a big herniation there. Let's see if I can grab it out. A rod lens scope uses a lens, a series of lenses. Lenses are always going to give you, yeah. Lenses are always going to give you a better image than a fiber optic image. So now, the reason there is a rod lens scope now available, but I don't use it. And the reason I don't use it is it's too bulky. The scope itself is much wider and bulkier, and I don't like it. I don't think it's as safe, in my opinion. So I've used this system where it's fiber optic because I think it's better. I have proven results with it, but also just to me it looks safer. I've tried using the other system and I really don't like it. Safety is very big for me. I mean, like, it's the most important thing for safety for a patient safety. And I know there are some surgeons watching this surgery going, how can you say that and you do this really complex surgery that no one else can do? This doesn't seem safe. Well, if you think about it, what surgery does seem safe, right? Anytime you're cutting a human body and entering it and cutting things out, there's inherent risk to that no matter what you're doing. And certainly this is safer than clipping a basilar apex aneurysm, which is something we do as neurosurgeons, which could kill you instantly if I go wrong. At least with this, I mean, certainly I could kill the patient, but that's always a risk with any surgery, right? And when I was a resident at Shands Hospital, I'll never forget that the most minor procedure we do is called a muscle biopsy. And it's where we just snip a little piece of muscle out from under the skin. And I'll never forget, we had a resident with a patient that died during a muscle biopsy. There's a herniation, by the way. The patient died from a muscle biopsy. It's literally like a 2-minute procedure that it's just so easy. I mean, honestly, tweezing your eyebrows is almost as risky. But the patient died. And they died because of a cardiac problem. It has nothing to do with the cutting the muscle out. It had nothing to do with the minor procedure. It had to do with the fact they were under anesthesia. So, number one, that highlights a few important points. Number one, it doesn't matter how minor the surgery is every one of them is serious, is risky, for the patient. And number two, a lot of people say, oh, I want anesthesia for my minor procedure. And I'm like, listen, anesthesia itself has risks. You don't want to subject yourself to the risk of anesthesia if you don't need it. And people just think anesthesia has no risk at all, but it does have risk. It's serious. And anesthesiologists know that. And they try to explain that to patients, but sometimes patients just get it in their head that they want to have anesthesia even when they don't need it for a minor procedure. So
We have a question.
People tell me I love being put out. It's
Really?
good experience. It's not very
Standby?
no fear
Yeah.
whatsoever.
Dr. Santiago was just telling me that some patients, when they talk to him, they have absolutely no fear, no concept of how potentially, um, you know, life-threatening, anesthesia itself can be, which it can be. But at Duke Spine, we do everything ahead of time with the anesthesiologist to really minimize the risk of an anesthesia complication. Yes. Zach, what question do you have?
We have a viewer asking, would a CT-guided nerve root block by an interventional radiologist be
Standby.
effective in relieving pain from an L5S1 compression?
Would a CT-guided nerve root block, this is called a selective nerve root block or injection, would it be effective at relieving pain? The answer is yes and no. If it does, it will be temporary. But a CT-guided or selective nerve root block is really, in my mind, has one purpose, and that's to diagnose the source of radiculopathy. In other words, the source of patient's leg symptoms. But honestly, I don't think it's necessary. I think it's an older technique. Personally, I don't order those. I don't recommend them. They're older. It's really, in my opinion, unnecessary most of the time to figure out what's wrong. You don't need to be doing it. Oh, come on. Oh, stubborn. Won't come out, so we have to go get it. There we go. Gentle. So my answer to you is the CT-guided selective nerve root block can certainly help figure out which nerve is affected, but in my opinion, it's not really that necessary. It would be like if you have a flat tire in your car from a nail, you just look and see. You can see which tire's flat, which tire has a nail. It just takes a little investigating. But you don't need to take the car into the shop to figure it out. You can see which tire's flat just by looking yourself. So I just find it unnecessary to do selective nerve root blocks most of the time. I haven't ordered one honestly in, I would say 20 maybe 18 years, something like that. It's just not necessary. You can tell where a person's nerve is affected by physical exam and MRI. Usually a CAT scan would be good. And sometimes a nerve test is necessary, but honestly, a selective nerve root block, in my opinion, is not necessary. You're going to order more of these tubular retractors,
Yes, sir.
right?
I'm gonna take care of that today, sir.
Let's get another 5 of them.
Yes, sir.
A lot of scar tissue here. This is all herniation with scar tissue. So we don't use fusion during this surgery. I'm not going to fuse the spine. And the reason we don't need to fuse these patients is because we're not taking the whole disc out. You see, the other surgeons that don't do endoscopic surgery, they actually have to take your whole disc out to get to the piece in the back. Where we're working on right now is a piece in the back, right? But we didn't have to take his whole disc out to do that. We went through the disc, but we didn't cut the disc or hurt the disc. We're just passing through with a tiny tube. Does that make sense? So we're able to do this by leaving the whole rest of the disc up front there. I didn't take it out. And because I didn't take it out, you don't need to do a fusion. This is the only surgery in the world that lets you get rid of the anterior herniation, pinching the spinal cord or the nerve, and not take out the whole disc. You all right there, Zach?
Microphone cord got pulled.
Zach's
We're all
like,
right.
wow, I had no idea. Are you just amazed, Zach?
Yeah, interesting information.
You didn't fall, did you?
No, the microphone cord got pulled.
Ah. Someone pulled your cord? Why am I having trouble? Now, which laser do we have?
This one right here is the one that we usually use, 100 watts. This is the one that
All
we
right.
use 20 watts.
Why is that, Luis?
Huh?
Why is that? Why is that?
Why is that?
Yeah.
Why
I thought we were getting the new laser.
Yeah. It's gonna be a new laser.
No, I thought it was supposed to be here today or last week.
On an 11.
Huh?
On an 11, right, Nico? The new laser is coming.
Oh, this is the demo.
Yeah, this is just a demo.
You didn't say
Yeah,
that. This is the laser that we're getting though, right?
Yes, but clearly not the demo, but anyway.
Yeah, but this is the model, everything. So and we're still at, what are we at? 20?
20.
It's working nicely. Very nicely. So I'm in the patient's left foramen right now. And this is all herniated disc. This is, you can tell it's very scarred. It's moving around. It's right where the herniation was on the MRI. And it's literally right where the nerve is. And you can see how much the bones and disc are moving now. There's a herniation right there. That was sitting on the nerve in the neuroforamen on the left. Okay? That's one of the important pieces that are coming out. So what other questions do we have there, Zach? Anything right now?
Not just yet.
And this is the pedal we're going to have?
Yes.
So for those of you listening in, for the last 13 years, I've always basically rented the laser from a company that's provided us with the laser and a technician. And finally, I'm pulling the trigger on buying a laser because these new lasers are pretty incredible. And this way we can also serve our patients better. The other company is, we have to schedule everything with them, and sometimes they don't have people available. And yet we have a patient who wants surgery right away. So this way we're going to be able to take care of our patients right away. Well, it's kind of a big deal. These lasers run about $100,000. And that's just for the basic unit. Can we have some more volume?
We have another question.
I'll take the question.
We have a viewer asking, how severe would the symptoms of radiculopathy and pain have to be for you to decide to be able to perform this procedure?
How severe would the symptoms of radiculopathy and pain have to be for me to perform this procedure? That's a great question. Thank you for asking. So there's really two answers. One is, what is the patient experiencing? And number two is, what does the physical exam show us? So sometimes patients don't have symptoms, but they need surgery. So we'll address that situation first. If the spinal cord is getting crushed by a herniation and the patient's literally going paralyzed, and I've been in this situation many times before, the patient will say, "Doc, I don't have any pain. I'm fine." And I'll say, "Yes, but you're losing function of your spinal cord and you're going paralyzed. You need surgery." So that's a case where the patient doesn't have symptoms necessarily, or they do have symptoms but they're not bothering the patient. People think surgery is for pain, but no, there's also surgery for a neurological deficit. So if their spinal cord's being crushed, they're losing balance, they're losing control of their bowel and bladder, they're having accidents or urgency to get to the bathroom. Okay, those are all situations where it doesn't matter what the patient's complaints are. I'm recommending surgery because the patients are not having pain, but they're having spinal cord damage or nerve damage, like weakness, numbness. I had a patient in clinic the other day who had atrophy of his legs. Basically, his muscles were wasting away from the nerve being pinched so bad in his back. And he said, "You know, Doc, I don't have any pain. I really don't feel like I need surgery." And I said, "No, you do need surgery because you've got nerve damage, and it's only going to get worse if you don't fix it." So that's a situation where the patient doesn't have much symptoms, but they clearly have neurological damage to the nerves and the spinal cord. So the surgery needs to be done even though the patient may feel like they're okay. That's one scenario. So to answer that question, it's if there's spinal cord damage or nerve damage, which can manifest themselves as balance problems, weakness in the arm or leg, numbness in the arm or leg, where they can't feel normal, or tingling, or loss of control of their bowel and bladder, or balance problems, or clumsiness of the hands. Those are all findings of spinal cord or nerve damage. I'm going to recommend surgery in that patient no matter what they're feeling. So this surgery is a perfect surgery for that kind of condition when it's due to a herniated disc, okay? Then you've got a situation where the patient has pain. And the pain can be in their neck, could be a headache, could be neck pain, it could be arm pain. Of course, we're talking about the cervical spine today, but it could also be lower back pain and leg pain. All right? So those are all symptoms that I would do this surgery for, pain in the patient. And a lot of times the patients that I operate on, they've already had physical therapy, it didn't work. They've already had non-steroidal anti-inflammatories, and they didn't work. Maybe even they've had shots, it didn't work. So those are the two scenarios. Patients who need surgery and don't know they need surgery because they're not having many symptoms, but they have spinal cord or nerve damage. And then patients who have pain in their neck or back, in their arm or leg, and they failed conservative treatment and they want to get fixed. So those are your two scenarios that I would do surgery for. And really, this surgery is for herniated discs that cause those symptoms. That's what we're working on right now, is a herniated disc. A degenerated disc is another name. Herniated or degenerated discs. Okay? Makes sense? We're just about done here. This is the last I'm going to do. And then we're going to go to the next level, the hardest level. We're going to go to the worst herniation, C6-7. That's next, okay? Beautiful. All done. All cleaned out. That's one disc. That took a while. Took a lot longer than I thought it would. This is a horrible song. Horrible music. Can we fast forward or something? This is like a wannabe rock and roll band.
We can't because it's serious.
It's serious. Well, I'm serious too. I'm kidding. It's Sirius XM. All right, so we're going to go ahead and get the laser protected back in the casing. And we're going to take ourselves to the next level. You can just turn the music off. So what we're going to do now is I'm going to need some help, guys and gals, with a shoulder pull. Make sure he's still relaxed. I'm going to take this tubular retractor out, apply some pressure to the veins and make sure we don't get any venous bleeding. But this tube is coming out, shot. And I'm going to watch on the x-ray as I do this so I don't accidentally take the dilator out. I want to keep the dilator in. And we're going to use that on the next level. But for right now, I've got to get ready to, yeah, that's good. I got to get ready to go to the next level. So here's what we need. I want this table a little higher.
The table?
Table up 1/4 inch to 1/2 inch. Good. Let's get another x-ray. All right, that's perfect. Shot. So as I took my hand off, the skin pulled the dilator up and out. Almost out, but not quite. Shot. Good. All right. So I need to be able to see the next disc. Better than that. I'm going to need a better pull on the arms. That's you. And maybe some inline traction. And I need the x-ray machine a little further south. So 2, 3, 4, 5, 6. Everybody agrees? That's 5, 6, right? So we don't need to see C2 for this. There we go. That's perfect. So what do you think? Table up a little more or just leave it where it is? I feel like that end plate, I feel like we need to wag it a little bit because I feel like we're not seeing straight down the disc space. So I would say a 3-degree wag either way to figure out how to get lined up. Now the reason why one disc is not lined up with the other is the patient has some scoliosis. Let's try bringing it further south and see if that fixes it. Now I'm going to tell you all a little secret about surgery. I'm just wondering. The secret about surgery for anybody who wants to be surgeon shot is that the more you prepare and the better prepared you are, the easier and better the surgery goes. 2, 3, 4, 5, 6, 7. All right, Luis, you're going to need to pull the shoulders. So I like to get everything as good as it could possibly be to give myself an unfair advantage. Just relax. Let's see where we are. All right, you got to do a better job than that.
No, I thought just relax.
Oh, okay.
Okay.
It was, but
All right, I'm doing it.
all right. So your hands are in the way. So here's the secret. Let me show you. Let me show you. You don't want to get higher up because you're blocking. You want to come lower down, and you want to grab the ball, and you want to not just pull down but push in. Okay, squeeze in. So in and down, and that will help bring the shoulders out of the way. Go. Shot.
Better?
It is better. That's not the way I had it, though. Are you still doing inline? Are you still pulling on the arms? Well, let's try one more shot. Let's see where we are. I think that's good. I think that's good right there. I think that's good, and we're good. So let me go ahead and get started. Everybody ready? Shot. Shot. We're outside. Let's get an AP. I want to make sure I'm relaxed just a little bit. Don't let it go fast. I need a coker. I've got it. Tell me when you're ready. Don't move. Don't move, Luis. Don't move. Shot. So I am pretty good. Could be a little more to Luis's side. Back to a lateral. Stay where you are and get ready to pull.
Yes, sir.
When you do pull, pull slowly. Shot. All right. Just stay. Shot.
This is a workout, eh?
Shot. Shot. Give me an AP now. Stay where you are. Tell me when you're ready on the AP. Shot. That's perfect. Lateral. Mallet. Stay where you are. Shot. Gosh, that's nice. Shot. Give me an AP. So AP means anterior posterior. It's the way we take the x-ray. It's from front to back. Front is anterior in medical terminology. P is posterior. It means the back, like the back of your neck. So an AP is a shot from the front to the back. It's perfect. I mean, we're a little bit scoliotic, but you can see we're right over the spinous process. Yeah, go back to a lateral. For those of you who are paying attention, you can see the endotracheal tube, and you can see a temperature monitor cable. Shot. This will be our last pull for the time being. All right, perfect. I'm in, like Flynn. Shot. That's good. All right, relax. Relax. Everybody relax just for a second. Okay, we're going to do a discogram, so I need a pipe cleaner. A discogram is where I'm injecting this disc with a dye. And that dye is blue. Believe it or not, hold on. The dye is blue, and it helps me, it binds to degenerated disc, which is your herniated disc. Shot. I want to make sure we're clean. Good. Yeah. And it also shows me where the annular tear is. Oh, this is an old song. All right, pull the shoulders, please. Good old-fashioned rock and roll song. Shot. That's perfect. Look at the dye leaking out the back. You see that? That's huge, a huge tear. All right, this is the level that, nope. You got to get this all the way in first. This is the level that has the biggest herniation. Shot. Shot. All right. I do need to pull.
We have a question.
Yeah, we'll take the question.
We have a viewer asking, what changes would you expect to be able to see on a post-Duke laser disc repair MRI for a disc herniation?
Okay, relax. What changes would what?
Would you expect to see on a post-Duke laser disc repair MRI after the surgery for a disc herniation?
All right, so what changes would you expect to see on an MRI after surgery, after this type of surgery, Duke laser disc repair? Well, first of all, you'll see the herniation should be structurally gone, and there'll still be, the disc will still look abnormal. You're never making the disc look normal again. That's beyond anyone's ability. Our goal is not to make the disc look normal. Our goal is to relieve the neck pain and headaches, arm pain, numbness, tingling, weakness, But if your spinal cord's being pushed on by a herniation, you expect that to be gone. And if the nerve is being pushed on by a herniation, you expect that herniation to be gone as well. I think this patient's rotated the neck. What's going on? Are we okay? I mean, I'm looking at the x-ray and it looks rotated from 2, 3, from 4 down. Can we derotate? And let's try to get one more good picture.
Yes, sir.
Grab and pull. Shot. Nice. Very nice. Yeah. That tells me right where I'm at. Shot. All right. So hopefully that answers the question. All right, we're there. Good. Relax. So what you see is that the normal disc in the front is still there, and we haven't done anything with the normal disc. We've just gone past the normal disc to the back of the disc where the herniation is that's pinching the nerve or irritating the nerve and spinal cord. We've left the front of the disc alone. So 95% of the disc will still be there at the end of the surgery. And because we're leaving 95% of your disc there, instead of taking it out like everyone else does with an ACDF or an artificial disc, because we're leaving 95% of your disc there that was there before the surgery, we don't need to do a fusion. We don't need to put a cage or spacer in. We don't need to put bone graft in. We don't need to do any of those other treatments like an artificial disc, because your disc, your natural disc is still there doing its job. And we don't need to take it out. The problem is not the rest of the disc, it's only the back of the disc. That's the issue. And that's what the laser surgery fixes, is the back of the disc. So the only change you're going to see on MRI is the back of the disc where all the symptoms are coming from.
Yes.
The other 95% of the disc won't be changed. What's wrong? So this is the disc that's really big, herniation. Oh yeah, look at that. I think we already tried the grabber, right?
Yes, sir.
So this is a newer herniation right here. I'm having trouble with the foot pedal, trying to get it to my foot. I think I got it. Let me just see. Are we on with the laser? Perfect, thank you. Now, this foot pedal, it doesn't need to be covered,
No, it does not.
so it won't short out or anything if water gets on it.
Nope. You can just take a regular sandy wipe and wipe it down afterwards.
Nice. I know the old foot pedals used to have problems if they got wet.
Nope. I know some accounts just prefer to cover it.
Look at that herniation coming out. You guys saw a piece of it? There's another piece. That's called a reverse herniation. We're the first people in the world to coin that. It's when the herniation comes back into the disc and into the tube and up and out. Remember, it took pressure to push that herniation out up against the spinal cord or nerve. So it's under pressure. And when you create a low pressure area underneath the herniation, it actually comes back. And that's what I'm doing by removing this stuff. It's just an incredible surgery. I mean, no other surgery in the world do you get a reverse herniation except the Duke laser disc repair, endoscopic surgery. Which is why we're the first to describe it in the world in our paper. For those of you wanting to look up the first Duke laser disc repair and second Duke laser disc repair publications, they're in the National Library of Medicine, and that's indexed in something called PubMed, P-U-B-M-E-D, PubMed. And if you go to PubMed, so you go to Google and just type in PubMed, and then type in Duke laser disc repair, you'll find our publications in the Journal of Surgical Neurology International. And I think the last time I did surgery, I was talking a little bit about it. The reason I chose that, there was a big herniation right there. You see that? Just came back in. The reason I chose Surgical Neurology International was that for the last 100 years, if you wanted access as a person to see what are the newest discoveries in medicine, you would literally have to pay about $200 to get a copy of a published article. You'd have to go down to the library and pay money, or you'd have to contact the publisher and pay money to have access. So I wanted to have an online open access publication where everybody could see it and not have to pay money for it. And so that's why one of the reasons I published in Surgical Neurology International. Plus it's a very reputable journal. At least it was until Nancy Epstein got in charge of spine. And she's just a nutcase. But prior to her, it was Dr. Jim Osman. And Dr. Osman's a reasonable guy. He's an old school neurosurgeon that is a big believer in the principles of science and fact and research. Whereas Dr. Epstein is the most biased person I've ever met that's in charge of a section of a journal. That's the problem. When you look at the New England Journal of Medicine, one of the top medical journals in the world, the chief editor-in-chief quit last year, I think it was, or the year before. She quit, and she's basically said that nowadays with the publishing is just, you can't believe anything anymore because it's all about a network of who knows who, and you scratch my back, I'll scratch your back. It's not really science anymore. It's just a lot of garbage being published. A lot of special interests really have taken over publication. And we're talking about insurance companies funding studies that show that surgery is not needed, so they don't have to pay for it, and then they cite their own article they funded. Happens all the time. Probably the biggest in spine, the biggest whore in the world for that is a guy named Eugene Karagi out of Stanford. Basically published a series of papers saying that spine surgery doesn't work, and he did it at the behest of the insurance companies so that they wouldn't have to pay for the surgery. The only reason I know that is because back in that day, they actually published who the supporters were of the research. And the supporters were this conglomerate of Blue Cross Blue Shield, State Farm Insurance, and basically they did a donation at Stanford to Dr. Karagi to basically write a paper saying that spine surgery doesn't work when we all know it does. And being the whore that Dr. Karagi is, he actually took the money and did some research, quote unquote research, and published the results, which are garbage. And of course he published it in a journal that he's the editor-in-chief for, so he gets to control what goes in the journal. And that's why they picked him, by the way, because he's an absolutely lousy surgeon, and all he knows how to do is take money, and he's a wheeler and a dealer. And the reason I'm bringing this up to you, the public, is because you all need to know the truth. These people are out to hurt you. They're out to hurt you by taking away your benefits, taking away what you've paid for, your opportunity for health. That's really what health insurance is your ticket to being treated and staying healthy and being treated when you have a problem that needs to be treated. And the insurance companies know the only way they can deny your care, paying for your care, is to say that it's experimental. And the only way they can say it's experimental is if there's somebody out there that published a study that shows that it doesn't work. The treatment doesn't work. And so the treatments that we've been doing for the last 100 years in neurosurgery on the spine to fix people, watch this cable, it's getting close to my face. Those treatments are now called experimental or deemed experimental by the insurance companies. Only in the last 15 years have they been really aggressively attacking everything we're doing. You've probably, if you're listening to this broadcast, have had an MRI or an X-ray that's been denied as experimental or not medically necessary. The reason it's not medically necessary is because they're calling it experimental. Of course MRIs under the spine are not experimental, but that's the game the insurance companies play so that they can make more profits. It's absolutely disgusting. As though billions of dollars a year is not enough profit for them. They have to harm people and their health to get more. But the worst thing is they're getting away with it, and partly because of people like Dr. Eugene Caragee, Caragee at Stanford. People like that they sell out to the insurance companies. And believe me, there's lots of doctors that sell out to the insurance companies. And I'll tell you why. The insurance companies pay very well for you to be one of their experts to testify for them. And they don't pay you to tell the truth. They pay you to create the truth. And that's what bothers me the most, is that public's being lied to. I don't mind if the insurance company wants to come out and say, yeah, we donated money to Dr. Eugene Caragee at Stanford so he could write a paper showing that spinal surgery doesn't work, so we don't have to pay for it. If they would come out and tell you all the truth, then I have no problem with it. I wouldn't be criticizing them. But it's when they hide behind anonymous donations through 501c3 charities that have names like Americans United for Spinal Health. I mean, it sounds like, wow, these guys are good guys, but in reality, it's basically the evil empire hidden in a bunny suit. And somebody's got to alert the rest of the world, right? And I guess that's just part of my job to do that. So, whether or not you like it, I'm going to be talking about it. Right, Luis?
Yes, sir.
Yes, we're desperately in need of irrigation. I don't know if you can see that we're having a huge problem here. We need visibility. So the irrigation is the liquid that's coming into the field that's washing away all the laser debris, like this little fragment of herniation, for example. And it gets the blood out of there so I can actually see. All right. These are all herniated fragments, by the way. I don't know if you can appreciate that. Some of you have watched many surgeries with me, and you're starting to see kind of the same things that I've been seeing for years now. You can see the herniation. You can see the end plates of the vertebral body above and below the disc. You can see the bone spurs. You can see the neural foramen. I just can't even grab that thing. It's too big. Oh, yes. Nice one. We got a big chunk of herniation out. But that's definitely a herniation because it's not attached and it's smooth, meaning it's been under inflammation for a while. By the way, we are at C6-7, which is the biggest herniation that I'm going to be doing today in this patient. And you can see there's still more herniation down here. There's going to be a while that we'll be working. There's another herniation right there that just popped out. See how smooth it is? It's smooth because of like inflammation working on its surface. That means it's been there for a while. So I'm teaching you all so much, and that's the idea. This is supposed to be a reality TV series of spine surgery. I honestly think people would enjoy a reality TV series with me and the Duke Spine Institute for a lot of reasons.
We have a question.
Yeah.
We have a viewer asking, do you ever experience reoccurrence of herniations, and or do you feel the disc sometimes becomes less stable after a procedure like this?
Oh, good question. So one of our viewers says, do you ever experience recurrent herniations in your patients? And is it possible that the disc becomes less stable after a surgery like this? There's another herniation. So to answer your question, number one, yes. My patients that have this surgery, definitely there's a risk of recurrent disc herniation, right? And that risk is much less than any other surgery that's available. And that risk is 1%. So 1% of the Duke laser disc repair surgery patients will have another herniation at the same place. And I can tell you this, it's always because they don't follow instructions every single time. I've never had a patient with a recurrent disc herniation at the same level we operate that followed instructions. So what happens is people are feeling so good after their surgery that they literally think that they can go back to doing everything normal again right away. And they ignore the restrictions that they have. And that's a real problem. And you know, if you ignore your restrictions after surgery, you're basically gambling with your health. That being said, you know, if they do have a recurrent herniation, they always let me know, and we help them out. So I'll give you an example. I had an ear, nose, and throat doctor. Of course, I'll never mention names, but he came from, I believe, Texas. So he was doing really well right after surgery. Why does it stop sometimes? Yeah, like I'm pushing on the pedal and it just stops. Any idea? I mean, I don't think I'm shifting my foot. My foot feels pretty square on the pedal. Yeah, like right there, it just kind of stopped. Is there a sensitivity button for the pedal? All right. So this doctor that had the laser surgery was doing so good that, you know, right after the surgery, he was so happy to be out of pain, and he just basically lifted something really heavy he shouldn't have lifted. Everybody has a lifting restriction after the surgery of 25 pounds for the first 6 weeks, and then it goes to 40 pounds. And this doctor ended up lifting, I don't know, I heard like a car, but I don't know if that's realistic. Anyway, he felt the pop in his back, and let's just say he was back again to have another surgery. And this time I think he's doing a whole lot better. We haven't heard from him in a while, and last time I checked he was so happy and he was doing fantastic. So to answer your question, the recurrent disc herniation rate is 1%, all patients. And I can tell you this, if you follow the instructions, the chance of getting another herniation is very low. If you break the rules, the chance of getting another herniation goes up. And then the other question was about stability. There is no negative effect on stability from Duke laser disc repair. The surgery you're watching, for those of you who don't know, is called the Duke laser disc repair. It's a surgery that I developed using endoscopic spine equipment and techniques that I learned from other surgeons around the world. And I modified it to make my own version that I think is the best. And what I found, to be honest with you, is that after the Duke laser disc repair, patients actually have better movement of their neck, and you can actually see it during the surgery. You can actually see the disc itself moving better. So there's no instability. We don't have to take people and fuse them. That doesn't happen. They don't develop instability. They do really, really well. Big scarred up herniation right over here. You can see the fibers of the PLL. So far, everything is going well. I know our patient's family is watching. This flow needs to go a little bit more north. Yeah, that's plenty. Any more questions there, Zach?
Not yet.
So this is the area where the huge herniation was before surgery. And look at how scarred in this is, folks. None of this is normal right here. Massively scarred. This poor patient has been suffering a long time. So earlier we saw some juicy, more recent herniation in this disc, but right now what I'm seeing is old stuff. This is probably at least a couple of years old right here, if I had to guess. And of course we're working right where the nerve root is, so I just have to be really careful. You literally want to peel the herniation away basically less than a millimeter at a time. You can see what I'm doing, the technique I'm using. I'm actually just slowly peeling the herniation away, and I'm kind of getting my reference points of where the spinal cord is. I can see the spinal cord. It's like right through there. You can see it. And I just want to be really careful. This is pushing into it right there. So I want to get that out. A little bit of herniation there. Just kind of annoying. Not really doing anything. And this is what I got to work on, this ridge of herniation right here. And you just have to be really careful, because I know you all don't know the 3D anatomy like I do, but the spinal cord actually comes towards you. It gets, we call more superficial or anterior in the middle of the disc, sorry, right where I'm at. So you have to be careful not to go as deep right here as you would, say, out in the foramen. And that's where I think, in my opinion, that's where the Koreans messed up. And they paralyzed a few patients because they didn't pay attention to that three-dimensional anatomy. I don't know that from anyone in Korea, but that's what I've heard, that they've paralyzed a few. And if you ask me, that's how they did it, if I had to guess. And here's where you just really have to be patient. There's no way to rush this part of the surgery. More herniation right there. But as you start peeling the layers away deep, you start to see the anatomy, the normal anatomy. You start to see what you're supposed to see. And then in surgery, you always want to use the normal anatomy as your reference point to where you are and what needs to be done. The normal anatomy is so important. So you have to have a good understanding of anatomy. That's one of the reasons why Dr. Roten selected me for UF the year I was chosen as a resident, is because I was literally the top neuroanatomist in the country. I had a commanding understanding of neuroanatomy like no other resident really before me. And part of that was just I dove into neuroanatomy in medical school and actually scored basically 100% on the final exam in neuroanatomy. I did so well that the USC in Los Angeles Medical School actually asked me to come and teach neuroanatomy as a faculty when I was a medical student. So it looks like our tip. That's very interesting. Let's go ahead and
June,
stand by.
can I have
We need to
the
clean up the tip. Some of the plastic,
Stripper is
blue
a gel.
plastic came down. Luis is asking for a stripper. Sorry, folks, if you heard that. I can't control what these people say in the operating room. No, but in all seriousness, you see all this? This is all scar tissue. This is all chronic inflammation. My question is how much of that is compressing the spinal cord? That's what I've got to figure out. And I want to take out only what needs to be taken out to unpinch the nerves and spinal cord. So, so at USC, I'll just keep talking since nobody's asking questions. USC is where I went to med school in Los Angeles, University of Southern California. The med school was about 125 years old when I was there. It's probably about almost 150 years old now. But in 125 years, they'd never had a student actually teach any class, let alone neuroanatomy, the hardest class there is. So being asked to teach as a faculty, as a medical student, fourth year was pretty amazing. But they also did me good because USC was it's about $45,000 a year just to go to medical school there. I think the tuition was $30,000.
It's taking so long.
What's going on, man? Huh?
Yeah, I break a couple of times.
Are you done? Let me see. Take your best shot. You get it or not? Put on the light.
Can you turn off the laser? Let me
Turn
see.
off the aiming, targeting beam. Yeah, I think you got
it's
it.
Good, it's good. Okay.
We're good. We're good. All right, it's a feel, man. You got to feel it. Have you ever taken the plastic off of a copper wire so you can twist the wires together?
Thank you, John. I appreciate it.
Anyway, USC is back then it was about 30 grand in tuition plus another 15,000 to live off of. And I was borrowing that money every year. So when I was invited to teach as a faculty, they actually gave me a salary of 30,000 a year, that fourth year. So I actually didn't have to borrow so much money. It was really nice. And now I can say I was faculty at USC in Los Angeles. You know that? I'm actually a faculty of USC Med School. Former faculty. I really loved USC. I think it was a great med school. Really good experience. It taught me so much. Really challenging medical school there. I think that med schools are trying to make it too easy for medical students nowadays. I mean, I just see these med students not really studying as hard or learning as much,
I think they focus more on score.
right?
Like, this is what you need for the test. This is what you need for the.
Yeah. Look at the scar tissue just peeling away layer after layer. This is that herniation at C6-7. Anyway, I really appreciated USC's, generosity with me because I was asking for financial aid and they just didn't have the resources to give it to me. And then finally that last year they helped me out. And despite that, I had a $250,000 in debt just from medical school 3 years. By the time I went to pay it off, because of all the interest for all those years, it's a shame that students would have so much debt, coming out of school. That's the first thing I did was pay that debt off. As soon as I got money, paid that debt off, paid my house off, and it was nice to be debt free. Yeah, you have a question, Zach? Gosh, it's incredible. Just the layers of scar tissue. This is years and years and years and years of scarring. It's incredible. Look at this. So we're definitely out in the epidural space, you know? And again, you don't want to gild the lily here. You don't want to do, yeah.
Dr. Patel's on the phone, says he has 2 of your surgery patients.
Uh-huh.
Do you want to see them today, and if so, how long before?
I'm going to be another hour. So have Dr. Patel come on in.
Right here?
Yeah. Ask if he can come in here, please. So
Have to change it, everything.
it's okay. Tell him to put a bunny suit on.
These are surgical candidates.
Oh, two patients that are surgical candidates.
Surgical candidates.
Well, that's different than my surgery patients. Oh, I didn't know. So, will you clarify that, please, Dr. Santiago? Will you please, or one of you, please clarify what he's talking about?
I believe there is a surgery evaluation.
Are they surgical candidate or are they my surgical patients? Candidates or post-ops?
They need surgery ASAP.
Yeah.
Oh, they need surgery ASAP. We're not doing it today. No. I'll be happy to see them in, say, 45 minutes. Probably the soonest I'll be out of here. Oh, that's what you get, reality TV, right?
I'm going to see if they can wait about 45 minutes.
Yeah, if not, I can see him tomorrow. First thing in the morning. All right, folks. So this is the worst level I told you about. This is C6-7, and I'm literally peeling away the herniation a millimeter at a time. I want you all to know something, though. This is really important. I haven't really talked much about this. But this is a broadcast to be truthful to people. What I'm doing right now is I'm doing what's called a decompression. That's where I'm taking the pressure off something. It's called decompression in neurosurgery terminology. I got to tell you, most surgeons don't do this. They don't do the decompression. They literally just do a fusion. And if you don't do the decompression when the patient needs it done, they're still going to have pressure on their spinal cord or their nerves. And the reason why most surgeons don't do this is because they can't see down here, number one. So if you're a neurosurgeon and you don't have the right equipment, you can't do this part of the surgery. You need a special microscope to do this. And those microscopes are $200,000 each. And if their hospital doesn't have it, they're not going to do it. They're just going to fuse and leave all this pressure on the spinal cord back here. Doesn't seem right, but to be honest with you, it'd be more risky for them to actually try to unpinch the spinal cord, not being able to see it, than for them to try. Now, the other half of spine surgeons that don't do this, they don't do it for another reason. They're orthopedic surgeons, and orthopedic surgeons are 100% not trained to do this part of the surgery, okay? I mean, there may be an exception here and there where they are, but 99% of them can't do this kind of surgery because they're not trained to do it, okay? This is a neurosurgeon's realm, not an orthopedic surgeon's realm. So I'm just pretty much doing what a good neurosurgeon would do, but I'm doing it with a laser instead of sharp metal instruments. I'm using a laser to do this. Now, a good neurosurgeon would do the same thing. They remove the herniation back here, but they use different instruments. So what's the advantage of the way I do it? Well, neurosurgeons have to take the whole disc out to be able to do this. I haven't taken the disc out. I'm not going to. I'm actually went to the back of the disc using my scope. You see that? And by doing it this way, I leave the whole disc there so the patient doesn't need to have a fusion done.
This is a bloodless field. So
This is bloodless too.
the structure to
Yeah.
the eyes.
Yeah, Dr. Santiago. Oh, look at that reverse herniation. You see it come out there? He's like, what's going on out here? I'm trying to crush this nerve root in here. What are you guys doing? We're here for you, buddy. You've been pinching his nerve for too long. You're unwelcome. All right. So, Dr. Santiago made the point that this surgery is pretty much bloodless, and he's right. How much blood have we lost? For those of you who've been watching, we've literally lost less than a drop of blood. And there's no other surgery in the world to fix his herniated discs. No fusion surgery, no artificial disc surgery, where you lose a drop of blood. So Duke laser disc repair is the only surgery where you lose a drop of blood. This is all herniation, deep. This is what we saw in the MRI ahead of time, this huge thing. And there's a bone spur, and the nerve is here in the foramen. And we're just about done with this level. And then we're going to do our last level. And look at all the movement we're getting now. So for those of you wondering who I am, I'm Dr. Ara Duke-Majan. I'm the CEO and founder of Duke Spine Institute, and I am a board-certified neurosurgeon. We're out in the foramen, and this is the patient's left side foramen. And we are about as far in the foramen as you can get. This is further than any neurosurgeon can get with a scope. Back to the middle area. We're going to look back at the other side one more time. See if there's anything else I need to work on. Maybe see what we got here. Pretty close to being done though. At this level. We have one more level we're going to do. How's our patient doing? Yeah. Perfect. I'm happy with that. The only thing I may want to try to get a little bit more right here, because I know there's still a little bit of herniation right there. This is that huge herniation we saw in the MRI. Let's go take a look. It's looking better. Remember I told you we use that blue dye to help determine where the herniation is, right? The blue dye stains to nucleus pulposus. Again, out the foramen. Beautiful. One of the reasons we do this broadcast is because I may not be here in the future, like when people start wanting to do more of these endoscopic surgeries. And I don't want this technology to be lost. It's so valuable to patients. And it's important that we start training surgeons to do this stuff, because surgeons are just doing old-fashioned fusions. And while a fusion will work, it's really not the best surgery for the patient. The future is non-fusion technology, and this is it. You're seeing it right now. This is the most advanced surgery in the world for treating a herniated disc. And yet, technically, it's extremely difficult to do. That's a bone spur, by the way, that I've been removing for those of you paying attention. It looks like a little dagger right on the nerve. Just about done with this level. Just another minute or two, and then we're going to move on to our last level. I just want to inspect this area a little bit more. That's posterior longitudinal ligament fibers right there, running up and down. Now, so that's important to know, because just below that it's going to be your dura, and that's the blue stain stuff right there. You can see this bone spur right here. I've taken out about 85% of it, and that's the foramen. I feel like we've gotten pretty much everything we can get here safely. I just want to look right here. That's, by the way, for those of you wondering, this white stuff is really super thick scar tissue. Some people wonder, well, how'd you get so good at doing this endoscopic stuff? And I think a large part of it is all the video games that I played when I was younger. They've shown that doctors that played a lot of video games actually make pretty good surgeons, you know, because of that hand-eye coordination. I grew up in the era of Atari, Commodore 64s. The era of Doom and all the other first-person shooter games that I love playing. Just don't have time to play them anymore, unfortunately. I want to know what we're dealing with. I have a feeling we're sitting right on the nerve root there. I think I might get a little bit more here, but that's about it. This is the hardest part of the surgery for those of you wondering. Right? It's called knowing when to stop. I think it's good.
Lights, please.
Something I don't know that I could teach anybody.
Can I light?
It's something you have to learn. And what I mean by that is it really comes from feedback you get from your patients after surgery. Knowing what you did and, you know, doing what's right. Yeah. Doing what's right for the patient based on their outcome. Right? After all, that's what's most important is not what you think you did as a surgeon, but what the patient, how the patient did. That's really what matters. All right, is that us? Fair enough. All right, so I'm going to take the tubular retractor out, leave the dilator in. Zach, any questions?
Not yet.
Take. All right, you all see this? Zechariah.
We see it.
So we're actually operating on a patient's neck, and we've done 2 of the herniations so far. We're going for the 3rd one. Now the 3rd one is honestly the one that's least important, but not insignificant. Shot. So I've got to come out of the disc space and make my way north to C45. Shot. C45 is the last of the 3 discs that we're fixing, but I need to make sure I get an AP. AP, remember, is anterior posterior, because the last thing you want to do when you're doing this surgery is you don't want to get off the midline. The midline is like a trench between the 2 longest coli muscles. You have your anterior longitudinal ligament there, you just slide right up it and you're safe. But the moment you get off to the side, I need a true AP. The moment you get off to the side, you can start, you get into the vertebral artery, or you can get into the muscle or the sympathetic trunk, and then you get all these complications, which we don't want. Stay where you are for a second. Shot. Lateral. You can see the scoliosis. All right, so I'm kind of caught on this little anterior spur. And really, bone spurs in the front of the spine don't matter. They don't affect people negatively, despite what you might have heard. It's all nonsense. Shot, you leave those alone. The only time we need to take those bone spurs out is when, AP, is when we have to put a metal plate on the front of the spine for a fusion. And you have to take the bone spurs out under those circumstances. Because if you don't take the bone spurs out in the front of the spine, the plate will rock like a teeter-totter on the bone spur. And that's really, really, really bad. You want to make sure that your plate, shot, Shot. That's better. Shot. Give me a lateral. You want to make sure your plate is midline but also flush with the vertebral bodies. Flush means it's like touching the whole vertebral body. So you do have to remove bone spurs. 2, 3, 4, 5. I'm not going to lie to you. I said earlier that was the hardest part of the surgery, but this is easily the second hardest part of the surgery. Or the first. Shot. I need an AP. I just don't want anybody getting too worried about it. Not yet, at least. We're close. Yeah, I felt we were too far. Shot. Ooh, too far over. Shot. Give me a lateral. This is slippery because there's kind of a bulge in the front, so it's sliding me around quickly. That's good. I need you to hold the neck still. Mallet. Shot. Shot. Give me an AP. All right, AP looks really good. Lateral. Take it when you got it. Give me a little extension. You got me? Extension?
Yes.
Shot. Shot. AP. I think it looks pretty good. Take this, go lateral. And that's in the disc space. Unless we're wagging hard, but we're not. Shot. Shot. Give me a pipe cleaner. Shot. 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 My gosh. Shot. Huh. A lot of junk in there, right? Oh well. Shot. You giving me inline traction? Shot. There we go. All right, so we're clear. Now we can shot. Shot. Give me an AP. All right, mallet. Stay where you are. Shot. Let's go lateral. Looks like the disc space is opening up. See it? Right at the tip, like a smiling mouth. Shot. 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 They're creeping along here. Shot. Can you give me a little inline traction? Feel better?
Okay.
Hmm?
You want the pipe cleaner again?
Shot? I feel it hitting. It must be hitting a bone spur. Shot? Shot? Yeah, there's just junk in there. Shot from going in. Shot? It's no wonder why. There's just a lot of, like... No, we'll try one more time with the injection. If not, we're just going to have to do it without it. Shot? Yeah. So this is our third and final disc. I need just a little more inline traction for another few minutes. Shot. AP. And we'll do one more pull, both of you. Not yet. Shot. Looks like we're out by the Freeman, which is good. We're in the midline with our tip. Perfect. Go lateral. I got it. Traction. Pull. Shot. 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 Stay where you are. Shot. I've gotten back as far as I can go. I think we're just seeing a side view of the vertebral body. Kind of an oblique. Shot. All right, relax. Definitely 2, 3, 4, 5. Bunch of junk there. Go ahead and make sure you clean that out really good.
Yes, sir.
Shot. Let's see where we are. All right. It'll work. Definitely he's relaxed still, right? Any questions from our audience? We're starting the third disc in a 3-level Duke laser disc repair. All right, come on. Go ahead. Did you get it or not? Yeah, you're fine. Grab your stuff here.
Yes, sir.
I need you to grab it so I can get in. Right here, right here, right here. You're pulling on the laser too much. All right. All right. And my foot pedal.
Look at some,
What?
Huh?
Come on, Luis. What are you doing? How could you have a mask that comes undone?
Looks like get stuck in my leg.
What?
Get stuck in my leg and me moving probably.
You gotta tie it properly so it doesn't come undone, Luis.
You got it, John? Thank you.
What was that? Stand by. Light on.
Light on, please.
Light on.
Light on.
Looks okay. That was a weird arc. Man, this disc is really just scarred up big time. See it? How grungy it is? The laser just shot back. That's a pressure wave. What are we seeing? What are we seeing there? That flash of green?
I'm not sure. It might be because there's not, like, it might have been a bubble, an air bubble.
Laser on.
Right.
I mean, there's a lot of bone spur, but that's a very weird. Right? What the hell?
Let's have
Laser off.
fire, please. John, please.
I need to see it right here. You're over here. I don't see anything. That is weird. Yeah. Let's get another fiber just in case. The shell looks fine. We're just going to change up the laser fiber because I'm not sure what that flashing is, and I don't want to take any chances. Look how stuck it is. See that? Can barely move. Remember the last level was just like this? Both levels were like this until we actually started removing the herniation. See all that white stuff there? So part of the reason we couldn't get the dye in is this white stuff here straight ahead is scar tissue, and it is so thick. This disc herniation has clearly been there for a long time, and lots and lots and lots and lots and lots of inflammation. That's the only way to make that much scar tissue, folks, is inflammation. So what causes that inflammation is the herniation, the nucleus pulposus. It elicits an inflammatory response. It's extremely aggressive. All right, we need that fiber. What's taking so long? Let's go, Luis. You gotta develop. No. You're gonna break the fiber. What are you doing? Turn the scope off. Let go.
I need to lights on, please.
Who wrapped this fiber? Huh?
We did it.
Let go. Who wrapped the fiber?
I wrapped it.
You specifically.
Yes.
All right. So what do you know to do next time? Not wrap it so tight, right?
Watch the tip.
I'm watching the tip. Don't worry. I mean, this is all sticking together. It's like you braided it. You can't braid it, you understand? You have to lay it down. one on top of the other, one coil on top of the other coil. Okay? If you don't do that, look at this. You went through. How many times you went through?
We stuck it 3 times, 4 times.
You don't go through like you're tying a shoelace.
No, it's not like that.
It is. Look at it. It's
Yeah,
like that.
now because it's tight, sir.
No, it's not because it's tight. It's because you coiled it improperly. Let go. I mean, look. Do you understand what to do right next time?
Yes, sir.
Or do you need me to explain it?
No, sir.
Okay.
Steel.
I don't think it's the fiber. I think it's just the bone.
I just talked to Matt real quick, and he said that it could be, if it hits the metal.
Yeah, but I don't see it hitting the metal. I just see it hitting bone. This is just really hard bone. And bone spur. There's just so much degeneration. Look at that, all bone spur.
It could be a lack of water in that area.
I think we're getting good irrigation though. I'm looking at the irrigation, it looks good.
About the temperature.
No.
Yeah, but you see the fiber?
What?
What's going on with the fiber?
No, it just.
So yeah, this is extremely scarred in. And this is the disc that I think is probably contributing the very least amount to his symptoms. And I can see why. It's just all burnt out. You know, there's really no active stuff going on. It looks like chronic inflammatory change. Wow, incredible, huh? Amazing. At least we're getting more movement now. Right? Any questions from our audience, Zach?
Not yet.
Kind of miss my blue dye. That's all PLL right there. Dystrophic calcification. Yeah, that's right. It is dystrophic calcification.
Do you have a question?
Yeah.
We have a viewer asking, what are the implications of chronic inflammatory change?
Well, chronic inflammatory change causes scar tissue, which is literally, this is what this stuff is. It becomes like concrete when it gets so thick. And bone spurs. So bone spurs and scar tissue. And obviously pain from chronic inflammation. What is that light?
I don't know what it is.
Why is there a light?
No, it's not this guy. I don't know what that is.
I know what it is. Huh? Turn the light on, please. Hi. Check here. Here? Yeah, it's wet. All right. All right. By the way, we really do appreciate the audience's involvement asking questions. No question is a bad question. God's honest truth. Every question gives me an opportunity to teach a little bit more. And that's what I enjoy doing. Really not much to do here. All right, we're done.
Lights on, please.
Laser off. Medicine. Oh yeah, I needed that, huh? All right, so Zach, let's take a look. We can show our audience the incision we made in the neck and show them how all three herniated discs were fixed with one incision that was 4 millimeters, basically. Pretty incredible. And we lost probably 3 drops of blood. So we're just holding pressure. It's standard to do that. There's arteries and veins and capillaries inside here. And we didn't hit any arteries, but there's always more veins than arteries, and there's even more capillaries than veins. How's our blood pressure? Good?
Yes.
All right, so we want to just hold pressure for a few minutes. And what we're trying to prevent is you can get a blood clot from bleeding from an artery, or you can get a blood clot from bleeding from a vein. And arterial blood clots get big, and they're dangerous, life-threatening. So we don't want an arterial blood clot, and we won't have one. But venous blood clots can sometimes get big enough to cause problems. So you always want to make sure you apply pressure. All you need is about 10 millimeters of mercury pressure, because that's what their patient's venous pressure is, about 10 to 12 millimeters of mercury. So I'm actually applying more than that, and that's keeping blood from coming out into the interstitial space. All right, so I'm gonna remove the bandage. Zach, you want to take a look here? Can you all see this?
We can see it.
Tiny little cut right here. That whole surgery was done through that little cut. It's endoscopic spine surgery. You won't find it anywhere else in the world. I don't know if the South Koreans are doing it anymore, but they were the only other place, along with one German surgeon that I know of. But in the United States, you won't find anywhere else but here at Duke Spine Institute. And normally, if other surgeons would do a big incision about that big or that long, and they would go in and take the whole disc out and put in a metal plate and inner body cages at each level. We didn't put any metal in. We didn't put any plastic. This is an all-natural surgery. We just went in and repaired the discs that were herniated and pinching the nerves. So our patient is asleep. He's intubated. We're going to get the tube out in a few minutes, wake him up, and then he's going to go home in about an hour and a half from now. Okay? I'm going to head over to the conference room and I'll answer any more questions. Anybody else want to say anything?
We are good. How about your shoes?
My shoes are great. Thank you, Luis. They're nice and dry. So you understand how to coil this thing?
Somehow you managed to get the water on my side, Luis.
Already? So now it was you?
Your shoes wet now? Seriously?
I had a blanket here before.
Good job, Luis.
He's remembering that story of,
Oh, yeah. Dr. Jacob. All right, this is a good time to type up your questions. I'll be there shortly and I'll answer them for you. I think these are history. Yeah. This is Dr. Digmajan, and we just finished up with the Duke Laser Disc Repair C45, C56, C67. Our patient presents to us from the islands. He has a history of neck pain and numbness and tingling in his hands, both sides now. Originally, when I first talked to him, it was in the left side, and now he's got it in both sides, both hands, forearms and hands. And developing weakness as well from the pinched nerves. So the MRI demonstrates that there are 3 herniated discs. The worst one is C6-7. The second worst one was C5-6, and the third was C4-5. And the patient was felt to have symptoms from all 3. And we just, instead of doing a anterior cervical discectomy and fusion, ACDF procedure, which would leave the patient with a very large scar, a lot of swallowing trouble, basically a high risk of complication. We'd require metal plate and screws and inner body cages to reconstruct the spine and restore lordosis, which is a curvature. 3 cages, bone graft. We didn't do that. The patient didn't want a fusion. They wanted a better surgery, which is the Duke laser disc repair that you just watched. And this is an endoscopic surgery. Basically, if you think about what's the goal for a surgeon who's treating a patient with a herniated disc that's pinching the spinal cord or pinching the nerve. Well, the spinal cord and nerves are in the back of the disc. So to unpinch a spinal cord or a nerve, the surgeon has to get to the back of the disc. And the only way that surgeons know how to get to the back of the disc is to take the disc out. So that's part of a normal surgery of the neck, is to take the whole disc out. So you got a big incision, you got to move over the carotid artery, jugular vein, esophagus, hopefully don't injure them, and then you got to contend with the disc that's there. To get to the back of the disc, you got to take 90% of the disc out. You shouldn't be taken out. So someone a lot smarter than me figured out, well, why not leave that disc there and just pass through it, kind of like we do with everything else in surgery. We pass through things and get to the part that needs to be fixed, and that's the herniation in the back. So somebody developed an anterior cervical endoscopic approach. It wasn't me. It wasn't Dr. Cambin. I don't know who it was. I believe it might have been somebody in Florida or someone in Germany or someone in Korea. But those are the 3 people that I know of that did anterior cervical endoscopic surgery 15, 20 years ago when I was learning. And I was trained by all of them. And basically, by leaving the disc alone, you are obviating the need for a fusion or artificial disc. So basically, we can leave the disc alone and just repair it. Hence the term Duke laser disc repair. So the surgery you just watched was a repair of 3 disc herniations that were pinching the nerves and spinal cord. What do I expect? How do I expect our patient to do? Well, first of all, everything went really well. We didn't have any issues with surgery, didn't have any complications. We lost 1 milliliter of blood, 1 cc, which is nothing, it's 10 drops. And basically I got everything done that I wanted to get done. Our patient's going to go home in an hour. They're intubated right now. They slept comfortably through the surgery, and they went to sleep, and when they wake up, their neck is fixed. They are going to have physiotherapy to get through. And physiotherapy basically is a reconditioning of the muscles and joints in the neck that really over the last several years have not seen much action because our patients had neck pain and arm symptoms that got worse with movement. So patients who have neck pain that gets worse with movement, basically they're going to not use their neck very much, so the muscles and joints get deconditioned. And the longer they wait to get it fixed, the more deconditioned the muscles and joints are. So our patient here is going to have some muscle reconditioning, which is physiotherapy, medical massage, chiropractic, and joint reconditioning, which is, again, the same thing, mostly chiropractic and physiotherapy. He's going to need physiotherapy after surgery. Physiotherapy is so important to making a recovery from the surgery. The surgeon can only fix a disc injury. They can't fix a muscle problem that is there because the patient hasn't been using their muscles for the last few years. So we expect our patient to go to physiotherapy and really improve the strength of their neck muscles over the next 3 months. As far as return to work, Duke laser disc repair patients like the one you watched just now can go back to work the next day. So our patient could literally go to work tomorrow. Of course, they have a lifting restriction of 25 pounds, light duty only, but they could do a full day of work, and most people do feel good enough to go to work the next day. So if there's work comp patients out there and you're interested in getting back to work quickly, then this is the perfect surgery. There's no fusion involved, no metal, and it's all natural, outpatient, and it works really, really well to cure neck pain, arm symptoms, headaches. Our patient does have headaches. He did have neck weakness and numbness and intermittent pain. So I expect all those symptoms to be gone after surgery. And we'll find out when we interview him. He'll probably be back tomorrow, and we'll do a live stream video broadcast tomorrow as well. We'll take our next question. So what are the lifting restrictions after the Duke laser disc repair endoscopic spine surgery we just watched? The lifting restrictions are 25 pounds for the first 6 weeks after surgery, and then they go up to 40 pounds after 6 weeks. I tell my patients I recommend you keep your lifting at 40 pounds or less for the first year after your surgery. Next. All right, that was our last question. I'm Dr. Ara Duke-Majan. I hope you enjoyed this 3-level cervical Duke laser disc repair. I recommend everybody go online with their phone to their app store and download the new Duke Spine Institute app. You're going to find incredible features in this app. One of them is you can actually upload your MRI for review, and you can schedule a video conference with me. I do all the MRI reviews myself, and I do all the video conferences currently at Duke Spine. So you get a free MRI review by the founder of Duke Spine Institute, and you also get a free video conference with myself, a board-certified neurosurgeon, to talk about your spine problem and what we recommend. Download the app for either iOS, Apple system, or Android. We have an app for either system, whether you have the Apple phone or you don't. And then there's lots of educational resources in there as well, where you can learn about conditions that Duke Spine Institute treats. So I hope you enjoyed the surgery, and until Thursday, 2 days from now, take care. Bye-bye.